Hello, everybody. Good morning, good afternoon, good night, wherever you may be tuning in from. Welcome to the second episode of season one of the Empower the Patient podcast, where we are a series highlighting the accomplishments, attitudes of changemakers advancing women's health and empowerment across Los Angeles. So today I have Dr. Hyunah Poa. She is actually a board certified internal medicine physician who practices primary care in Palos Verdes. She earned her medical degree from Northwestern University and completed her residency in internal medicine at Thomas Jefferson University in Philadelphia. Then she joined UCLA faculty in 1994, progressed her way into the Iris Cantor UCLA Women's Health Center, and then she actually served as a director of women's health from 2007 to 2009 at the Stamford Hospital Center for Integrative Medicine and Wellness in Connecticut. So, welcome. Thank you so much for coming on.
Thank you, Caitlin. I'm so excited for your podcast and honored to be part of this really cool movement. Thank you.
Yes. Okay, so my first question for you is, as a primary care physician, what is different about treating women versus men, and why do you enjoy this specialty?
Well, thank you for asking that question. I think a lot of people don't really consider that in the old days. But fortunately, I think all the top medical schools and residency programs are training primary care doctors to notice the differences.
Mhm.
Besides the obvious body part differences, that does, of course, impact specific screenings based on gender. So of course, for women, cervical cancer screening, breast cancer screening is quite important with mammograms, pap smears. Men need discussions about prostate cancer screening, and again, related to organ-specific things for women, reproductive health, pre-pregnancy counseling, family planning conversations, proactive conversations about perimenopause, education about what might be normal or versus disturbing or symptoms of menopause that could be treated, or at least discussions of what the options might be. So those would be the obvious gender specific differences in primary care. I think the things that are a little bit less obvious, but do get discovered in research studies as well as play out in the delivery of healthcare to women versus men. There are known differences in disease incidences. For example, there's a higher incidence of heart disease, stroke in men at a certain age. So, of course, women get heart disease and stroke, but the
Right.
classic timeline is typically men might see it in their 50s, 60s, and in women, it might appear about 10 years later on average. Of course, there are exceptions and family histories and genetic predispositions that
Mhm.
a primary care doctor should, ask about and treat someone based on their specific backgrounds and risk factors, as well as the different incidences in different disease states. There are also differences in test outcomes. Again, for example, in heart disease, if you were to order a basic treadmill stress test on a
Okay.
woman versus a man,
Okay.
traditionally the stress test is more accurate in a man, meaning if
Mhm.
a man presents with chest pain, shortness of breath when he exercises, and this is a new symptom for him, or let's say he never exercised before, he's overweight, approaching an age, he discovered that his uncle died at age 50 of heart attack, and he's getting really concerned about the, 20 to 40 pounds he's gained over time. If his doctor says, well, let's order a treadmill for you and let's see if you actually have heart disease or not. The stress treadmill has a higher accuracy, like a match for if there's disease, you will see an abnormal test result versus in women. So in
So
a
with
woman, go ahead.
I was gonna ask, like, if you were to do that same test in women, let's say that they present the same exact symptoms as the situation you were describing with a man, how would it be less accurate with that same exact baseline situation?
So especially in heart disease, and that's why I picked that topic, unfortunately, it's both directions. One, It's less common that women have classic symptoms. So textbook symptoms written in medical school are signs of a heart attack are, heavy chest tightness in the mid chest or left chest,
Mm-hmm.
pain radiating down the left arm, sweating, diaphoresis, dizziness, nausea, etc. If someone were to have all those symptoms, classically, that would be very accurate in a man for a heart attack. The same symptoms in a woman presenting might be more likely something else.
I see. Okay.
And, conversely, so for example, if a woman actually has heart disease, let's
Okay.
say, you had a crystal ball and you knew that a woman had bad coronary arteries, it's
Mhm.
more common for a woman to not necessarily present with chest tightness, shortness of breath, sweating, etc. More likely, she might present with very vague symptoms, such as feeling dizzy, weak, um, just can't explain why she just doesn't feel good.
Mhm.
So in both scenarios, it can be really tricky to want to order a test for a woman, and then if you order a test to feel good that the results are accurate enough. So
That
it's really, yeah,
um
so go ahead.
I've noticed a lot in my shadowing in the ER at least. Yeah, there's I guess with women, now that I'm hearing this, there should be even more emphasis on preventative care. So, as a primary care physician, like in regards to like their work schedule and whatever they might have going on in their life, like what makes you decide that those test orders are necessary despite a woman
Mhm.
like maybe, yeah, being a mom at the same time, like she doesn't have too much time on her hands?
That's a great question. So luckily, I'm getting senior in my career, so I have the benefit of many years of experience and, reading academic studies and following guidelines because we have access at UCLA to guidelines that are current. The good news is a lot of things don't really change, and the things that do change really help us a lot. So the things that have not changed in primary care are we are taught that 90% of your diagnosis lies in the history. So if a primary care doctor really takes the time to listen, ask the right questions,
Mm,
they can, come up with a pre-test determination or bias, and then
okay.
really should follow through on that instinct. Same thing. I always tell my patients, especially my female patients,
Mhm.
trust your instincts and be your own best advocate.
I
So
see.
I have so many stories of women who were told, "Oh, your mammogram's normal, the breast pain you're having, don't worry about it anymore." And they persisted and ended up, they did find breast cancer. Or someone had unusual symptoms. They got a normal stress test, but because there was a strong family history, came to seek another opinion, and got the correct tests. So I had just given a simple example of a stress test, but there are about 6 kinds of stress tests. And so in women, it's more accurate if a woman does not just a basic treadmill test, but a
Mhm.
stress test with an imaging study, such
I see.
as either an echocardiogram or a radioactive dye study, which cardiologists know, and now primary care doctors know this as well. So never fear, women, if they go to a good primary care doctor, if there are worrisome symptoms or new symptoms, and there's a family history and risk factors,
Mhm.
primary care doctors are pretty alert to that nowadays.
That's good to know. That actually leads perfectly into my next question about the nonverbal cues that clinicians can look for, especially regarding social determinants of health. Especially when
Mhm.
you mentioned like having those predetermined criteria when you want to evaluate someone and then you want to order XYZ tests for them. So, what would you say those are those nonverbal cues?
This is a really great question because as primary care, you have very limited time.
Yeah.
Unfortunately, over time, we're given less and less time. We get 30 minutes for a new patient, 30 minutes for a physical, 15 minutes for a follow-up or return or an urgent visit. So in a very short amount of time, a doctor needs to do their best to figure out what are the underlying issues that affect the care that's about to happen, what is the patient presenting with, and what do we need to focus on. And we do know, and UCLA is very good in the training program at emphasizing that social determinants of health are very important in women, especially. Not that they're not important in men, but obviously, if you think about a woman with difficult social determinants of health, such as poverty or being a mother or being abused or not having a job, etc., truly it's going to impact her health in possibly devastating ways. So nonverbal cues, I mean, there are the obvious. So if you see someone with poor hygiene, a bit unkempt, or obvious signs of abuse, you're going to be able to ask. What I've noticed now, the less obvious nonverbal cues are more personality. And I think over time, it definitely helps if you've seen someone more than once. But even on a first visit, often as a physician, or maybe it's me, you have a sense and you can't explain it. I think a good primary care doctor will try hard to act on that sense and continue to try and figure it out. So whether it's make sure there's a follow-up visit or
Hmm.
or take the time to extend the visit and ask more questions about social determinants of health. And this leads into I think we're going to talk about a little later. If we have enough time, I'd love to share an example of a recent patient of mine that exactly this happened, and it took me quite a while to really figure out what the problem was because we just could not get anywhere in helping her diagnose and treat a very large lung mass. And
I s-
really, it was completely about social determinants of health
that
because of
would
her.
lead that
Mhm.
would lead perfectly into this question too. Just can I ask like what position were you in? Like where were you in the country since you have so much experience in so many different states? And then we can get into that story too.
Yeah, I love that last question as well. There are definitely regional differences. I've been lucky enough to practice in California and Connecticut, Northern California, come back to a different part of Los Angeles.
Hmm.
And I think politics plays a role in what a region believes are the offerings to patients in their primary care, as well as specialty settings for care. So, for example, Planned Parenthood is
Hmm.
now going to be unavailable to women in certain states. Um, Fortunately, we still have access here, or we're trying to make sure that access continues. Um, Other differences might also be related to culture, tradition, um, back to the first question about differences in men versus women, it's very common for men to not come to the doctor or avoid preventive visits because either they're prioritizing work or they just see themselves as capable and they're fine and they don't want to do anything unless it's actually broken or feeling completely seriously ill in their, sense of well-being. Whereas it's a little more common for women to worry. There is a higher incidence of anxiety, of course, documented in women versus men. It's
Hmm.
almost double. And so that will affect how frequently women access healthcare and how they present. It does not discount their symptoms, however, because now we're knowing more and more that emotional states, psychiatric states, do adversely influence health. There is increased incidence of cancer, heart disease, stomach problems, sleep problems, etc., that really can result in health consequences. So it's very important for a woman, absolutely to see a doctor when they're not feeling well. And you don't have to be too specific about not feeling well. I think it's better for a woman to, seek care. And if they don't feel satisfied with the result of tests or what they're told, like I said, be their own advocate, go again, seek a second opinion, because there should be an explanation for why they're not feeling well, or at least, options for whether it's nutrition, counseling, medication, continue to work on how to have wellness, not just disease treatment. Other differences in women's health, I would say expectations and cultural influences
Right,
definitely play a role. You know,
right.
Western women are a bit more accustomed to speaking up for themselves. I do notice, for example, Asian women tend to want to discount symptoms, tend to avoid serious diagnoses, want to, shove it under the rug and not spend a lot of money on their health care,
Mhm.
avoidant of doing serious tests, avoidant of facing dire diagnoses, which can be pretty dangerous if something is delayed in diagnosis and care. And then even during the treatment phase, culturally, there are differences. I've noticed that differences in Hispanic women versus Caucasian women versus Asian women, how they process diagnoses, how often they involve others in their care, such as family or a loved one or a friend, to include them in the disease process, care, conversation, which can greatly impact how a woman processes the information during an acute phase diagnosis, how supported she feels during a serious illness, and recovery. Because let's face it, if you're seriously ill, you could use a little help. And
That
so I
is true.
think women who can access that or feel empowered enough to go ahead and accept help and access it are going to have a better prognosis. So if anything comes of this conversation, I would want women to, don't try to be too strong all the time, especially if you're not feeling well and ill, accept help.
So going back to that patient with the large lung mass, what was
Mhm.
what I guess like how many visits did it really take to, I guess, really narrow
Mhm.
down maybe a vague set of symptoms that she presented herself with?
Yeah, I mean, I'm bringing it up and I'm just so horrifyingly embarrassed it took so long, but it's not an excuse, but kind of
Mhm.
a reflection of our healthcare.
Okay.
She had a different primary care doctor. I met her in a short visit. Three different doctors were trying to help her get to the correct tests and treatment, but she didn't trust anyone. It turns out the trust issue was related to, and it took me probably until the sixth visit to gain her trust. And it
Mhm.
was really by asking those kinds of questions of, could you tell me why you don't want to do this test? Is there anyone living with you? Where do you live? And the first time I asked those questions, she had said, "Oh, yeah, I live somewhere." And then when I got a little more nosy, discovered she was living in her car. She had been doing that for 4 years. She had lost her business in Long Beach. She did not want to tell her two sons about her illness at all. She did not allow me to call them to involve them in her care.
Mhm.
People thought she had a psychiatric diagnosis. They thought she was just crazy and psychotic. And then even with that, we almost filed conservatorship to take over her right to make healthcare decisions. And fortunately, I contacted someone to address this kind of question because I was not familiar with it. And it
Yeah.
felt very uncomfortable to take away someone's right to make decisions. So I felt fortunate that I got a bit educated. And when I really changed our plan and said, I need to see you every week for a while. I just want to see you every week at the same time until we figure out why we're having roadblocks and let me help you because I really want to help you. In those visits, finally, we discovered all these issues of homelessness. She was smart enough to have access to social money, food, help. She found safe places to sleep in her car. She found safe places to take a shower. And so she had presented looking okay. She had reasonable hygiene. She's very well spoken. And it was not an issue of money avoiding the test. It was an issue of she didn't want to bother anyone. And culturally, she wanted to just accept her fate. If she had cancer, she did not want treatment. She did not want to bother her sons. She thought that she would die and that she would just go with this diagnosis and die. So with her, we're actually still in the process of gently educating her about the options, what options there are to support her without bothering her sons, if that's her wish, because
Mhm.
she has that right. I support the right of a person to make their own personal, choices. Sometimes they look stupid to us, but it's, a person's right as long as they are of sound mind, which you demonstrate by showing that you understand the consequences and the risks, then that's informed consent. So I learned a lot by taking care of her, and it was quite humbling.
Yeah, would you say that like what changes in her attitude do you think you can draw from those visits? Starting from the
Mhm.
very beginning when she was very reluctant to share anything to now that she's maybe been shown a few treatment options and she is showing up to these follow-ups weekly. So
Mhm.
that's great.
Well, again, fortunately, she's the one who just laid it out in very clear English and very clear communication. She said, all along, my issue has been trust. I don't trust anybody. I don't think
Mm,
anyone knows me. Nobody has asked me the things you've asked me. Now I
mm,
trust you. I only want to see you because I trust you. And so, I think in healthcare nowadays, we don't really think of that too much. But again, culturally, or just in her state and her social state, of course she's going to be distrustful of strangers. Of course she's going to be distrustful if someone she doesn't know very well as a physician starts saying, we need to have you sign over your legal right to speak for yourself as the first conversation when
yeah.
she's told that she might be dying of lung cancer. Of course, she's going to avoid coming to the doctor's office if it feels like someone's trying to further endanger her right to live how she wants to live. So,
It's very it's moving but kind of shocking to me that one sentence such as I want to see you every week. I want to check in on you every week. I think that speaks a lot more than when you first hear it. I'm sure she probably took that what you said back to her car and really thought about it and then
mhm.
tried to reflect your body language, your tone. Can I ask, are these telehealth visits or was this in person?
No, she has never been late. She shows up
Mm,
on time, early for every single visit. And also, what I decided because she's not really accessing electronics, she might have poor memory, we've discovered, and certain people, that's also why they wanted conservatorship. But I thought about it and I thought, she still demonstrates informed consent. Just because you're losing your memory a little bit does not mean someone else should take over your entire life.
mhm.
I'm living this with my parents right now, and I see it in other elderly patients. I believe in dignity, and I believe that we have the right and should be respected with dignity to, as long as we're able, to still have that power and empowerment as a patient, whether female or male. And so it really, again, was highlighted in this particular patient's care. And so we used a manila folder, and every visit I would write in handwriting on her folder because the pages and pages of type print that we give every patient when they leave, it's 2 or 3 pages of, a whole lot of language and typing, and it's hard for someone who's used to another language to distill, well, what's important here, what do I need to know? And so each visit I would just write, 2 or 3 things like the next visit, the time, what we're going to talk about,
I
any
see.
medication I recommended. I wrote down her test dates and times on the piece of paper, and she has
Mhm.
never lost it. We have a running account of every visit, and that became very effective for her to be able to remind herself, see it, trust that it was something that she and I talked about, and look forward to it. If she forgot what day we made the appointment, she could see it on her folder.
Mhm.
Um, so it took me a while to come up with that plan. Again, humbly, I wish I'd thought of it earlier because I do what I do, and at work we normally just print something on the computer and
Yeah,
patients get an after visit summary and you send them on their way and figure it's up to them to follow up. It's up to them to figure it out. But it does highlight a huge crisis in mental health care, both in California and throughout our country. So maybe that can be another one of your podcast topics is mental health care in women as men as well as men.
I agree. I think that that is it's interesting for me to be hearing a story like this and hearing about your experience because obviously you can't necessarily practice every specialty to the same age with the right amount of efficiency. So, for example, like ER medicine, it's not recommended that you practice past 60 years old because it is a very fast-paced atmosphere.
Mhm.
Whereas primary care or family medicine or internal medicine, you can keep practicing because those visits tend to be a lot more, I wouldn't say slower, but just taking more time to get to know the patient. So
Mhm.
I think that's very important, that everything you've shared so far, even if you do have those 15 minutes, just kind of really honing down to the patient. I want to see you every week, giving them the same time so that they don't forget. And then going back to the generations thing, I'm Gen Z, so it wouldn't even really cross my mind to think of, okay, let me write this on a manila folder on the front so I don't confuse my patient who is maybe geriatric age, can't really read through everything and filter out everything or
Mhm.
want to skim through anything because that's boring and that's also very
Mhm.
time consuming and
Mhm.
difficult for them to comprehend, especially medical terminology. So, yeah, I think you addressed some really good points and very well said quotes that I will be pulling out directly from this recording. But I just wanted to say thank you so much for coming on. There were so many good lessons to draw from this, especially in women's health, where very vulnerable population. I think you did an amazing summary on just even using a simple stress test on the treadmill, saying that it's not as accurate, and then also talking about a patient that you are currently still seeing on a weekly basis too. I think that you might have been the pivot in life that she needed, honestly. I think that's amazing. And that just shows, I guess, how much you can really grow as a primary care physician. Despite you being in the field for many years, you could still learn, even from just taking on a new patient, no matter what age you are. So I think that was all very beautifully said. And thank you so much for sharing this too. Do you have any last remarks?
Um, I would like to end on a little more up note. I feel like that story was a little bit of a downer, so I would point out as well, I've been lucky enough to see the regional difference in our area. For example, in the South Bay, we are a very cohesive community, very proactive in so many ways in education. A lot of people take pride in taking care of their health, being proactive about their health. So I do want to highlight as well that, especially in our region, I've been fortunate enough to see people who take it upon themselves. They don't just rely on their doctor, but they seek out opinions. They keep track of their own primary care. They might seek concierge medicine, which is just a way for a patient to be their own best advocate by paying a little extra and buying out
Yes.
a doctor's time. So a doctor is not seeing 3,500 patients but maybe 300 instead. A big difference in how much time a doctor has to spend
That's true.
and pay attention to, as I said, the history part of an interaction, patient versus doctor. So I just wanted to, point that out that I think that's something that has developed in healthcare that can greatly benefit both women and men. Some people are lucky enough to have that access, not everyone, but people who could have that access, that is a difference um, in healthcare by gender or by station as well.
Yeah, that is a very good direction that I'm noticing too. Um,
Mhm.
and yeah, so that is pretty much the wrap of our episode. I titled it Coast to Coast Lessons in Women Healthcare, but this can apply to pretty much, I would say, even beyond the United States healthcare system too. So thank you very much again. Thank you for tuning in. Um, Hopefully, we will see you again, maybe about like a follow-up story as you see your patient more and more.
It'd be great. Thank you
Yeah,
so much, Caitlin.
thank you. Have a great rest of your day.
You too.
Alrighty, everyone. So that was Season 1, Episode 2 of Empower the Patient. We are a podcast series highlighting the accomplishments, attitudes, and advice that changemakers advancing women's health have to offer in terms of empowering them across the Los Angeles County. So, thank you very much for listening, and we will see you next time with another very special guest.